Thanks very much, Lou. Three things first before we talk about our journey and discuss whether it has any connection to you. First of all, there is a third Yankee fan here. That's a heck of a way to endear yourself to a New England crowd, isn't it? I mean, so let's just put that right out there. Secondly, this is probably one of the most beautiful backdrops that I've ever had. So when I see you staring intently forward, I'll kid myself into thinking that I've mesmerized you. And then the third, there really are two obvious common themes that make me feel at home. The first is your chair and your president and your docs talking about quality. And that I relate to that all the time. And the second is it's an amazing thing, but at our place in here, there are, the only seats that are open are the ones in the front. So just thought I'd mention that. What I'm going to do is quickly go through our perfect structure and perfect sociology, which has allowed a lot of things to be done that I think you're striving to do. And then the question that we should ask in the discussion, and I'll zip through these, but the slides will be available for you afterwards if you want them. The question is, how much of what we're doing here is scalable and generalizable to other demographies and other structures? We're perfectly designed, since we have both the payer and the provider in the same fiduciary structure. And we have every component of the provider system, and we're heterogeneous. We're not like Kaiser Permanente. We have a huge number of non-employed, non-Geisinger physicians giving care in our facilities or sharing the care partnership with Geisinger employees taking care of patients in our region. Our insurance company has many more non-Geisinger, non-employed physicians in their panel, and in fact more non-Geisinger hospitals, so that if we do something which is innovative in the sweet spot where we have more direct leverage and more kind of common sociology, we have an ability to ask whether it is translatable in the more heterogeneous real world. But we have the entire complement, and 50% of our payer is our own Geisinger insurance company. 50% is Highmark, Blue Cross, Capital Blue Cross, Northeast Blue Cross, and Coventry. So it's a very interesting fee-for-service for about 50%, and essentially capitated or quasi-capitated for 50%. And that sweet spot between payer and providers where we do all of the innovation experiments. It's obviously much easier to do the innovation and change the incentives and change the flow of information in that sweet spot than it is between us as a provider and a non-Geisinger payer. The other thing that is implicit in this, but not explicit, and you should know, our organization is not a hospital-centric, hospital platform-driven organization. Our organization is driven by our physicians. And so the most important thing for us has been, for the last 100 years, taking care of a population of patients, not keeping the hospital full. Now that sounds glib, but it is a philosophical precept. And our job over the last 14 years was to figure out how to have a sustainable business model with that virtuous value system. Because if you don't have a sustainable business model, no matter how virtuous your value system is, you're going to be in trouble. So this is where we live, and it's a very interesting demography. It's rural Pennsylvania and post-industrial Pennsylvania, not Philadelphia, not Pittsburgh. We have about 3 million people in our overlapped, that is payer and provider markets overlapped. The payer market is gray. The heavily outlined, dark bolded is the provider market. We have some of the most stable population in the country outside of the Deep South. We're older, we're sicker, we're poorer as well, compared to just about every other part of the nation except for the Deep South. So we're very proud of what we've been able to accomplish with this sick, old, and poor population. But we do have significant advantages because 15 to 20% of the population we serve is multi-generational. And that gives us a number of extremely interesting possibilities for getting care given in a multi-institution, or multi-generational setting outside of a hospital institution. Our insurance company is also now in Maine, in New Jersey, in Delaware, and West Virginia, working with non-Geisinger select providers, which is very interesting. And in fact, Lou, we've been trying to get together with Coastal Medical for, I think, about 6 months now, and the schedule hasn't worked. But Coastal is a very well thought of, excellently run organization that's trying to figure out how to preserve what they're doing without necessarily becoming incumbents in something larger. And that's basically what a lot of our acquisition and merging and partnerships have led to. And I'll talk a little bit about those relationships with the non-Geisinger folks in the other states in a few minutes. Now, we have recently consolidated hospital platforms. We originally, about 14 years ago when I started at Geisinger, were coming off of a dysfunctional merger with an academic medical center, Hershey, Penn State. And that was the baseline, and both Hershey has recovered from that and Geisinger has recovered. But we dealt with about 12 non-Geisinger, non-owned hospitals where we were committed to taking care of our patients close to where they lived and not necessarily incenting them to come to the big house or the hubs. And it was good for us, it was good for our patients. Those hospitals were intrinsically much more efficient than the big house in Danville, which was our founding Geisinger hospital, or the hubs that we'd built in Wilkes-Barre. And the reason for that is in a lot of these small hospitals located out where 250 of our community practitioners were in about 80 sites, they didn't have encumbrances that were the same as the encumbrances in the hubs. They weren't doing research. They weren't doing a huge across-the-board commitment to residency and fellowship training. So, we wanted to keep as much care out in those platforms convenient to the folks, much more efficient, unless the folks had to come in for tertiary, late tertiary, or quaternary care to the hubs. What's happened recently is that many of those smaller hospitals just did not have the balance sheet. It wasn't so much the operations, but the balance sheet to be sustainable. And they were either going to have to change their function or they were going to have to go to another competing organization that had a different value system than we had, mainly CHS, which is a for-profit out of Brentwood, which is the other big consolidator in our area, and they're hospital-centric, or we were going to have to figure out how they could become part of our family. So we've recently gone from 2 hospitals to 8 hospitals, and the primary motivation for those joinings has been our commitment to keep care as close to where patients live as possible. We are maintaining those hospitals to a large extent on our own operating margin stress, but we're maintaining them because we have this commitment to take care of patients close to where they live and move to a much more efficient caregiving transaction. And we can over the long term deal with that because if we attack total cost of care to the benefit of the patients, that comes directly to the business benefit of our insurance company. And we can do the internal transfer pricing. So it's a lot more straightforward than dealing with Highmark or Capital Blue Cross or Northeast. So this is the sweet spot. About 50% of the care that's given in our insurance company is by one or another of our Geisinger physicians at one or another of our Geisinger facilities, and about 50% of the payer for the entire Geisinger effort comes from the Geisinger Insurance Company, and that's where the innovation engine is. We are extremely systematic about setting our strategic goals, and about every 4 to 6 years we try to discuss our goals through as much of our family as we possibly can. We now have 22,000 family members, so it becomes a huge effort to try to simplify the goals, get as much buy-in in a reasonably systematic way as possible. But our two major goals now, which I want to focus on for the rest of this discussion, is our hospital-based value reengineering and our value reengineering of taking care of patients with multiple chronic diseases. And then the question, is it scalable, is it generalizable out of Shangri-La, which is what we call our part of Pennsylvania, Shangri-La. Some people call it Kentucky. I call it Shangri-La. So I'm not going to ask my wife what she calls it. So she's a Rhode Island girl. So there are two touchstones that really have kept us moving forward in a positive direction over the last really couple of decades. And one touchstone was almost it was an epiphany that I had. There was an article written by the RAND group in 2003, first authored by Beth McGlynn, that said that a huge amount of what we do, we writ large in healthcare, is either too much, too little, or wrong. And this was a look at about 14 different markets across the United States, a whole series of hospital-based services or ambulatory services. And expert panels basically said, how often was the care perfect? And so what this said was about 45% of the time it was imperfect. Now I looked at this article and I said, as I was right in the middle of my honorable part of my career, I was actually taking care of patients at the time. And I said 1/6 of the economy, and somewhere, let's just discount 40 to 45%. Let's say there's some methodologic stuff in here that you could argue with. Let's take it down to 30%. 30% of what we do, which is cost built into the system, either doesn't help the folks we're responsible for or may actually hurt them. Just think about that. So wouldn't it be interesting if there was some way that we could extract as much of that stuff that either doesn't help or hurts and redeploy it? I mean, that's an incredible amount of value. And some of it can be given back through the insurance company because of our unusual fiduciary to the people who are buying the insurance by lowering premiums. Some of it can be given to the docs who actually help to create the value proposition. Some of it go into CapEx budgets and help with the sustainable business model. But this is one of our religious. This is really one of our religious, I think, starting points. The other key point is the realization over the last 2 decades that what we began to realize in the early 90s, that there was no relationship in looking at cost versus quality. And this is data from Arnie Milstein, started to be published in the early 90s. We understood that if you went to one hospital or if you went to one region of the country and you paid a lot more for care, either as an individual or as a population cohort, it was not necessarily related to your getting better quality. So we all kind of began to accept that a number of decades ago. We've gone much beyond that now in most of the road tests that Lou is referring to that we've done at Geisinger. We now believe that if you want to define a population cohort, whether it's hospital-based care or ambulatory disease management, that has the worst outcome in terms of quality, near-term and long-term quality, you look for the highest cost. So the highest cost is almost always related to the lowest quality. Now, what this means for me as a professional and for my colleagues is that if you can convince people to re-engineer, fundamentally think about how to re-engineer a lot of the high-volume stuff that we have been taught to do in a certain way for a long period of time, you're able to look at the proposition that you may have 2 really interesting outcomes: better quality, both near term and long term, and lower cost. So it's not either or. It's not like during the Hillary Care debate. Some of you remember, as citizens, we were told you could either go after cost or you can choose quality. And that was really a false polarity, So this is critical. This kind of realization has become critical to us because what turns most of our men and women on in our journey, in our experiment, is helping patients and not necessarily cutting costs. It's my job to make sure that we have a sustainable business model. It's Lou's job to make sure that it's the chair of your board. But what drives everybody, what drives everybody who's working with us in the family is to continually improve the outcome of the humans that we're responsible for. So these are the categories, the general categories of road tests that we've kind of gotten known for. The first is our version of re-engineering hospital-based care, and we had a kind of a sexy packaging around that. We did a single price, which we negotiated with our insurance company, including our taking financial responsibility for all of the complication care that would occur, and we discounted that price based on about a 50% discount, looking at the 3 years of caring for complications before we re-engineered. So we would have to improve our outcome by a factor of 2 in order to break even for that part of our business between us as providers and us as payers. So we really put our money where our mouth was on this. But we weren't crazy. We didn't make that deal with any of the non-Geisinger payers. So again, there was a bit of a hedge. Our proven care chronic disease was based on taking 20% of the total compensation that was going to our primary care physicians. We have about 250 primary care physicians, again, located in about 80 sites. And we have a huge uptick in nurse practitioners and PAs and pharmacists. So we've re-engineered our care with a lot of scope of practice liberalization. But we took 20% of our total cash compensation and took it away from RVUs, or panel size, or number of patients seen, and we directly linked it with fundamental change in how that care was given. And we looked at committing to a bundle of best practices for prevalent chronic disease. And if every year our community practitioners, with our experts that are hospital-based specialists, if they would have a significant delta in the number of diabetics, or the number of congestive failure patients, or the number of COPD patients, or reactive depression patients, if we had a significant delta, which was a goal set year by year, for more of those patients having achieved all of the appropriate goals that everyone decided would be most likely related to best outcome, then they got that 20%. And if they didn't get that 20%. So it was a way of linking what was happening in the real world in taking care of patients with our strategy. And then our version of advanced medical home was a very interesting synergy between our insurance company and our community practice, and I'll talk just a bit about that, and then we'll open it up for discussion. So the first, the beta test for our hospital-based value reengineering was elective coronary artery bypass. And what we did was we looked at, we inventoried our individual hospital-based variation. At the time we started this, we had 3 hospitals. We had about 9 cardiac surgeons, probably 35 cardiologists, who all claimed that because Geisinger was different, there was no variation. And so we inventoried our variation. It was huge in terms of just about every aspect along the way. And it took us 18 months to come to grips with about 150 items that were categorized into 42 categories, that all of the men and women, from the time of diagnosis of a coronary artery disease leading to CABG, from the time of diagnosis through rehabilitation, every patient would achieve every one of those best practice bogeys. And we built it into our electronic health record. We had a number of physician assistants kind of expediting this across our entire system. And the question was, if we started with a hospital-based service that already was good, we have something called Pennsylvania Healthcare Cost Containment, where we were compared in terms of our elective heart surgery outcome in cost and quality with almost every other high volume system. And we were already good. Could we take something that was good and make it even better? And what would it do with our cost structure? And this is not rocket science. This was stuff like consensus or default best practice for starting antibiotics, default best practice for stopping antibiotics, default best practice for preparing the sternum for a median sternotomy, continuous monitoring of blood sugar, whether or not you were a diabetic, optimum temperature at discharge from the operating room to the recovery room, and it went on and on. All the stuff had already, by the way, been looked at by the disciplines, by both cardiology and the cardiac surgeons in the Society for Thoracic Surgery. It's just that none of that had been actually engineered into the entire episode. And there had never been a commitment before to say, we're going to get to 100% on 100% of patients, and what would happen. And when we started, we were not bad, but with a tremendous amount of effort, we got up to about 100%. It's biologic; it bounces up and down, obviously. And we published this a number of years ago, and it's been sustained, it's been modified. But what you can see, the first thing you can see is that we had very good outcome, and it got even better. It got even better. Now, it's never going to be perfect because it's biologic. There's tremendous variation. There's recidivism in terms of what happens when someone comes into the system, someone leaves the system. But basically, we took good outcome in a well-led service on both the cardiology, cardiac surgery side, the nursing side, what have you, and it made it better. And the interesting additional fact was we did it with less cost, significantly less cost. And for every other complex process in life, it would be intuitive to you, I'm sure, that if you got rid of unjustified variation, not justified variation, we allow the individual practitioners to vary what they're doing. They just have to, from the default best practice, they just have to justify it in real time in the electronic health record. That's all. And that's another story, how often there was, in fact, justifiable variation. It was much, much less frequent than we had all thought it was going to be before we started this process. So less cost on something that was already looked at as being extraordinarily value-laden, a better outcome on something that was already thought to be extraordinarily good outcome. And we've now gone through a second iteration of this, and we continue to improve. It's a mechanism of continuous improvement without having to do a randomized clinical trial, because as all of you who are real docs know, most of the patients that we take care of, and probably that you take care of, are not going to ever accrue to a randomized clinical trial. And most of these changes are not one variable at a time. And this is now our portfolio of hospital-based and hospital-associated value reengineering. And this is one of the reasons why we have done well, even with our hospital-based business, as we get closer and closer to reference pricing on the fee-for-service side. So even if you're not switched all the way over to a population health type of business model, even if you're not in a capitated environment, if you're getting paid less for each unit of work you're doing, which is what we're experiencing now in our residual fee-for-service, you've got to have some mechanism for extracting that unnecessary cost. So I'm making the pitch now that this is a good approach even in this very complex transition from fee-for-service to ACO or shared savings or quasi-capitation or whatever you want to call it. So then let me give you a snippet of the outcome here for our chronic disease commitment to re-engineer. And this is the thing that's related to the 20% of compensation that is not based on RVUs or panel size, patients seen, number of tests ordered, what have you. And we started first with 27,000 type 2 diabetics that we take care of. And we committed to 9, they're not 9 listed here, but 9 best practice goals that our endocrinologists and our primary care physicians agreed, and it's off-the-shelf goals. It was not, a bunch of people sitting around the table davening, but it was stuff that had never been built in and into the commitment for taking care of type 2 diabetes. And when we started this, we have great men and women working very, very hard, and we're electronic, completely electronic. Our partnership is with Epic, and if we have time, I'll comment on that afterwards. But with a huge amount of work, we got about 99% of our type 2 diabetics over a period of 6 years up to 7, 8, or 9 of these goals being achieved. Now, some of these goals are contraindicated. If you're over 70 and you have heart disease, you're not going to push the A1C down to below 7. So a lot of this stuff is contraindicated. So if you get this huge cohort up to 7, 8, or 9, it is a big deal. And what we found is with 3 years of patients in this process, we started to see something which just actually knocked my socks off. We started to see a significant decrease in the probability of heart attack, stroke, diabetic retinopathy, and nephropathy. Nephropathy is not on here. Now, amputation rate didn't change at all because amputation rate was low no matter what. The vascular surgeons were incredibly good at salvaging limbs, but I mean, if the question is, and this is going to be published actually next month, the American Journal of Managed Care, and it's the second experience. The first experience that hinted at this was a group out of Minneapolis, St. Paul called Health Partners, where they changed a commitment to bundle best practice for chronic disease management. But within 3 years, to see diabetes-related morbidity and mortality affected, for me, is just amazing, absolutely amazing. Now, we haven't even done the economics of this, but you can imagine the economics. If you're really attacking total cost of care, and if, like us, you've got a partner or you've got a fiduciary payer, I mean, that comes right to our business model, and we can do the internal transfer pricing. So for a lot of that 20% that we're paying our PCPs and our endocrinologists, that's not based on RVUs, a lot of that comes for achieving these goals from our insurance company, which is directly benefiting in terms of the financial aspect. Now, obviously, the patients are benefiting tremendously. And we've done the same. CAD, we're looking at CAD right now in terms of the real benefit for the patients. If you aggregate all of this stuff, plus if you do a little bit of additional re-engineering in the community practice sites, our version of advanced medical home was really remarkable in looking at 25 to 30% decrease in hospitalization per 1,000, which is sustainable for our entire, and we have, we have a catchment area of about 3 million people. And our market share on the payer side is for Medicare Advantage is well over 80% or 90%. So I mean, and remember how stable that demography is. So it's a perfect experimental model for us. Now, the real issue is what happens to the hospital when that volume goes down. We can talk about that in a few minutes. But the main reason, the main re-engineering here was to take a nurse that was paid for by our insurance company with insurance company data, real data, which would be customized for the entire team. So it was usable, immediately usable. And that nurse was embedded in the community practices. And he or she had to do 2 things. Number one, for 150 of the highest utilizing, sickest patients, the 73 to 78-year-olds with 3 or 4 chronic diseases taking 15 to 20 pills a day. That's the profile of our sickest patients, basically. Anything that happened to that patient had to be triaged through the nurse, so that nothing that happened to that patient 24/7, and there was obviously coverage, whether the patient came into the community practice or whether the nurse went out to the home or went to the skilled nursing facility, everything had to come through that nurse. And the idea was to prevent that 7-pound weight gain and shortness of breath that would occur on a Friday evening and lead to an ER visit and a default admission. I mean, that was it. This is not rocket science. This is absolute precision in blocking and tackling and really fundamentally trying to re-engineer the community practice. And in this case, with a very unusual sociology of an insurance company employed nurse partnering and actually being socialized within the team of the community practice. The second thing that nurse had to do, in addition to triaging the 150 sickest patients, was to make sure that the information that was almost real-time information available from the insurance company as well as from the electronic health record was meshed and usable by the docs. Most of the information that we get from non-Geisinger insurance companies is not immediately usable. Most of the information that we get from CMS is never usable. And you can't do this kind of re-engineering unless the human beings that are responsible for taking care of folks across the desk or across the bed actually have usable and almost real-time information. And you probably remember that when we were debating ACA, there was a claim that within 10 years we would bend the cost curve, the big cost curve of healthcare writ large by 1%. What we found with this combination of commitment to bundle best practice for our prevalent chronic disease patients, as well as our version of advanced medical home, we've had a sustainable bending of our cost curve by 7 to 8% per year. 7 to 8% per year. Now again, that is great for our patients and their families. That's number one. But number two, because of our fiduciary, with 50% of our payer coming from our own insurance company, it's a sustainable business model. It's a sustainable business model, as long as we can do the internal transfer pricing, which we can. And one of the questions that you might ask is, well, why haven't those other payers actually asked to be on board for this? So again, I'll leave that with you. If you want to ask it, we can cover it with the discussion. This is all about changing behavior. And it's about changing behavior of our providers. But I think the upside over the next 5 to 10 years is changing behavior of those that we serve. And whether they're our insurance company members or whether our patients. And one of the things that we are focused on, and as you look at this slide, this is an incremental step forward, but I am convinced that the relationship between us as providers and us as patients is going to change dramatically over the next few years. And an example is an experiment that we started about 3 years ago with the BI Deaconess. The BI Deaconess and their practice plan, and there was Harborview in Washington State, and Geisinger did a beta test where they opened up a small part of their primary care practice, and a number of their patients agreed, in our case about 9,000 PCP patients, to have immediate access to all of the progress notes that were written by the providers in real time through our electronic connection. And the success of this was so astounding in the following ways. Number one, patients and their surrogates were incredibly active in looking at what the doctor said. Number two, the correction, the self-correction of errors was amazing. That should be no surprise because, the doctors, instead of being, or the patients, instead of being passive, were active participants in this. And number three, the docs did not know we had actually turned the experiment on. Now, as someone who's been leading docs for a while, that is probably the highest success you could ever get, that the docs don't know you've actually done it. Now, I don't know whether that's true, Lou, with you or not, but right. So what we've done, and what we've done, as probably most of you know who are PCPs or endocrinologists or congestive failure experts, what we've done now is first of all, we've opened this up throughout our entire system. So all of our progress notes, with the exception of psychiatry, psychology, and the emergency room, are opened up to all of our patients in real time, including the progress notes of our trainees, which is very interesting. And we've linked a metric, which I think is a very important metric as a baseline surrogate for patients being actively involved, and that is the metric of medication adherence. As you're probably aware, an incredibly high percentage of folks that you hand a prescription to will never get it filled, or if they get it filled, will never take a pill, or if they take a pill, will never continue that medication. And so if you're trying to optimize chronic disease management, that's a very bad way to start. And I think what it means is that patients, although they may shake their head in order to get out of the office, don't really agree with you in the first place. Or they may not understand why you're doing what you're doing. Or they may have economic situations, they may have financial situations that they're just not going to be comfortable talking about. But that's just one aspect of what I think is a much bigger commitment to having patients essentially relating to us in a much more active way. So the question of scaling and generalizing, we're attacking this in three ways. Medicaid fee-for-service in Pennsylvania is gone. It's gone. And we are one of three Medicaid managed care companies that is now jumped in. We ended up in March of last year with 120,000 new Medicaid members. And I went to my board, and it represented about $600 million of revenue and no known margin. And the reason we did it was twofold. Number one, we're still going to be taking care of those patients, and we were already taking care of 85,000 of those folks. And I'd rather be in on it on both sides so that we can see if the sweet spot working together could fundamentally change the care of a lot of those Medicaid patients, because you talk about complete chaotic caregiving. And that you'll find that in two of the three components of Medicaid, not the third, but two of the three. So that's a huge experiment of whether we can scale and generalize. The other reason we're getting into it is because, quite frankly, I think Medicaid is going to be one of the fastest growing payers, like it or not, in the country. So if we can't figure out how to deal with that, we're in trouble. We're in trouble. The second part of the insurance company scaling is what I said within West Virginia, Maine, New Jersey, with Meridian, non-Eastern Maine with Eastern Maine Health System, in West Virginia with West Virginia University, and in Delaware now with a wonderful non-Geisinger organization called Christiana. And the question there is, can we take the same payer-provider relationship, which is very, very different? It's not us as antagonists trying to figure out on the insurance side how little to pay for each unit of work, and on the provider side how much to get for each unit. But it's really to say what group of patients, whether it's hospital-based care or chronic disease management, can we work together to improve the outcome? And if we can improve the outcome, how do we define that? What are the metrics, the early metrics? And then if it makes sense, as it did with us on our business model, how do we split the proceeds? And what we found in Eastern Maine is, after 1 year, the same incredible decrease in hospitalization per thousand. We've seen that in West Virginia. We've also seen that if the hospital CFOs, no offense if your hospital CFO is here, but if the hospital CFOs are left to their own devices, what happens when the utilization goes down? The price per unit goes up. It's amazing how that works. And so systems are made, they're almost biological. They're really made to come back to the median. And that doesn't work as you get consolidation of the, of the blues, and it doesn't work because Medicare fee-for-service is going to continue to whack the amount per unit and what have you. So that won't work for very long. But I think I think we've proved with Eastern Maine now and with West Virginia, we've proved that this is scalable outside of our area and outside of a Geisinger-employed milieu, which is interesting. The other aspect, which of course has led to a scaling experiment, is this kind of frenzy of consolidation. And we have acquired a hospital in Scranton. We've acquired a very small hospital in Shamokin, which is Cole Township, hospital in Bloomsburg, which is a very small university community about 7-8 miles from us, a hospital in Lewistown, which is up near State College, and then we have two others that are coming to us, one in Harrisburg and one in Atlantic City. And most of those are, the rationale for most of those joinings have been hospitals that we were already dealing with that had no sustainable business model. And we were either going to have to let them go over to a competitor that had a fundamentally different hospital-centric approach to healthcare, or we were going to have to let them essentially just degenerate their function or their quality, and we were unwilling to do that. And then we created a company, and this is an interesting company that takes a lot of our intellectual property in care management, predictive modeling, and our modifications of EPIC, which is really an incredibly intense and aggravating aspect of EHR, and one that I'd like to be able to move beyond over the next few years. But it takes all of our intellectual property on the cool stuff that we've done, and it takes it out to other systems, whether they're on the provider or the payer side. Our intent, and I think that the Geisinger model is in fact one of probably 6 or 7 models that has some really interesting, good prognosis for expanding, but in different ways with modifications. Our intent is not to expand the way Kaiser expanded under David Lawrence and the way it may expand again now by bringing in employed Geisinger docs and what have you. It's to work with other groups, whether it's through what our insurance company is doing or whether it's through what this for-profit spinoff is doing, and basically trying to modify and see if this will do 2 things. Number 1, help patients. That's the main thing. And number 2, figure out sustainable business models, particularly for the hospital-centrics that are having to move to some population health business model. So we're getting much less revenue. I mean, everybody understands that there's probably $750 billion being transferred from Medicare to the under or uninsured in various ways. That's happening by really whacking Medicare Advantage, and it's also happening by really making Medicare fee-for-service almost untenable. If you're still in the fee-for-service game and you're going to be dealing with Medicare, I don't have an easy solution here. I don't think there's going to be an easy solution. I think Medicaid managed care, and again, I don't know what the situation is in Rhode Island, but certainly in Pennsylvania, that is expanding dramatically. It will expand. And the governor in Pennsylvania has been trying to get his own variation, but it will eventually expand. And I think the only way we're going to be able to do good to our members and our patients is to be in on it on both sides of the house, both the payer and provider, and re-engineer the kind of care. If those folks are still defaulting to the emergency room and having the most inefficient care, it'll be a disaster for them in terms of their outcome as well as for the cost aspect. So that's, I believe that we're now in the midst of big-time price controls, and I think that's going to continue. We've got an expansion of regulatory commissions in every way. These multiple payment incentives are the fee-for-service that's continuing plus quasi-capitation. And again, I think that the grand unifying theory in my mind of that is you got to re-engineer no matter what. I believe that there will continue to be consolidation both on the provider side. The real issue is whether you're consolidating with, with an entity that has your value system or not. Because we've seen, I call it the era of the monopoly game. There's a huge amount of consolidation that's going on, but at the end of the day, the question is, are you in your new form with your new partner going to be able to deliver higher quality care at lower cost? And if that doesn't happen, it's not going to work. It's not going to work. And then I think if we continue to have significant issues, I think we'll see global budgets. We have global budgets in a way in Maryland. We have global budgets in Massachusetts. We have global budgets in a way in Vermont, in Oregon. So I think we're going to see global budgets and the cost shift will go away. I mean, that's already going away because of the consolidation of the commercial insurance. So again, I'm delighted to be here. You all are rightly proud of your entity. I think we share a view of giving care close to where patients live without sacrificing any quality. And I'm happy, Lou, to take any questions or discussion or criticism. So thank you very much.
Does anyone have any questions at this time? So everyone can hear.
If the public decided that they had had enough of all these national challenges that you mentioned on the last slide, and we're looking to become more competitive and less regulatory in terms of the approach of government to the medical industry, how would that impact your model, and how could your model be applied in a more competitive and less regulatory way?
Well, I think it's happening. I think what you're suggesting is actually happening in two ways. First of all, in our market, many small businesses are going to get out of the insurance as a indirect benefit. They're willing to pay the penalty if there is a penalty. And of course, every day there's an administrative change in ACA, so we don't know if there is going to be a penalty. But I think they're going to basically let their employees go to the HIE, the Health Internet Exchange. And so those folks will be on their own, making their own decisions, basically. Now, that also has a lot of risk, but at least individuals will be making their own decisions in a more or less competitive way. With the government trying to define what's in those various plans. The second thing that is happening, and I think will happen very rapidly, is the move from defined benefit to defined contribution. I mean, I think most of us who are around went through that, and it was lightning speed in terms of our pensions. And I think it's going to happen over the next 2 to 3 years, where even large companies are going to hand their employees a check once a year. Now, this year it would amount to about $12,000 per employee, leaving about $6,000 to $7,000 for the discretionary money that has to come out of the employee's pocket. And then those folks will be told, just go out and get your own, health care, whatever you want. So I think that's happening. So I believe that's not the rate limiter, the problem. I think the problem is how we in healthcare get the information out to those that we serve about where they can go for the value proposition, because there's just so much competing information out there that confuses folks. And most of what comes out of the government, whether it's PHC4 in Pennsylvania or CMS or whatever, most normal human beings cannot understand, and they cannot make decisions on that basis. I think if we could, if this type 2 diabetes effect after 3 years is scalable. I mean, just imagine if there were a place in Pennsylvania that could, or in Rhode Island, that could say, we have data that if you're with our system in 3 years, you have this chance of having a heart attack, which is fundamentally lower, or this chance of having a stroke, or this chance of having retinopathy, which is fundamentally lower than anything, at any other region or area, what have you. And if you could get that out, people would choose. If they had type 2 diabetes, they would choose, I believe. But we haven't had a way of figuring out how to get that information out. So I think it's getting people to understand, it's not as easy as just advertising the damn purple pill, in the CBS News every evening. That's easy. This stuff is hard. This stuff is really hard to get out to even intelligent folks who are not involved in systems like this and systems like ours. I think the other issue is stakeholders. I mean, you didn't ask me about Epic, but I'm going to talk about Epic. I think the EHR companies are now, some of them are modeling themselves on big pharma. I think they're designing their systems to be as rigid and proprietary as they possibly can. And what I would love to do, and we're starting to look at other possible partners, because Geisinger's been with Epic for 20 years and is known as, and we've done well by Epic, but I want a system which is open source, that competes on the basis of applications, not on the basis of fixed pipe, and will allow me to take my modifications into whatever system you have. And that's now designed not to be possible. So I think that's another rate limiter. I think fee-for-service, though, will go away. I really do. And I think Medicare fee-for-service will go away, not by some politician standing up saying it's over, but by just whacking the amount that you get for each unit of work until it's absolutely unsustainable.
So most of you know that our healthcare system has been involved in a deliberate exploration of the options that partnering with a larger healthcare system would offer us. As I said earlier this evening, while the hospital is currently financially strong, we cannot ignore the changing healthcare environment in which we exist. It is clear to the Board of Trustees and the hospital's senior leadership that going along with the status quo will not be a winning strategy for this organization. We want to be proactive in our approach to protect, strengthen, and preserve this valuable community resource, South County Hospital Healthcare System. That is why we have spent considerable time, effort, and energy over the past 18 months in discussions with 3 large healthcare systems in our region. All are fine organizations and all expressed an interest in having South County join them. Based on the responses of the 3 systems to our detailed requirements for what we consider essential elements in any possible partnership merger, the board decided to limit any further discussions to 1, and that was South Coast Health System. South Coast was singled out because it most clearly shares our values and our culture. And we already heard that mentioned tonight. That's one of the key assets, that if we don't have that, there really is not the groundwork for us to move on to anything else. So that was critical for us. We have made site visits to South Coast inpatient and outpatient facilities, and we have been impressed. Like South County, their connection with the communities they serve is a close, personal, unique, and treasured relationship. South Coast also sees the importance of our system maintaining a local board of trustees with considerable governance authority. We believe a locally based board with representation on South Coast Board as well is absolutely necessary for this organization to continue to meet the distinct needs of our population. We believe participation by folks who live and work in this community is essential to understanding the challenges facing South County and to directing its course for the future wisely. South Coast also shares our vision of growth. They have committed to financial support of the investments in business initiative proposed in our RFP. Among the initiatives South Coast has endorsed are our Cancer Center, updating our Women and Newborns Care Unit, growth in our physician alignment, and our needs for significant IT improvements to manage the risk that we know is on the horizon. As advances in healthcare are achieved, we want to be sure that we can continue to offer you the most current, best quality care here, close to home. Many of you here tonight are generous supporters of the hospital, and I want to assure you and every member of the community that South Coast understands and supports the fact that philanthropic gifts to our endowment and the hospital's retained earnings, called our pool investments, will be preserved and invested by our investment committee and used for the citizens of Washington County, guided by our local board. For those of you who don't know much about South Coast, just a few comments. South Coast Health System is a regional, community-based, nonprofit organization comprised at this time of 3 hospitals: St. Luke's, Charlton Memorial, and Toby Hospitals, a visiting nurse association, and more than 40 outpatient centers in both Rhode Island and southeastern Massachusetts. The South Coast Centers for Cancer Care are affiliated with the renowned MD Anderson Cancer Center. Recognized for excellence, safety, and customer service, South Coast provides many advanced clinical procedures, such as open heart surgery, brain surgery, and weight loss surgery. More than 500 primary care and specialty providers call South Coast home. Like South County, South Coast has strong community roots and a passion to deliver high-quality health care in the community setting. And like Geisinger Health System you've heard about this evening, South Coast has been successful in creating an integrated health services organization that better manages population and provides quality care at a lower cost. They have achieved market leadership in their communities by remaining true to the model of patient-centered care delivered in a setting where safety and quality are top priorities. Their programs support an informed, empowered patient, and we also see as key to improved population health management. If you'd like to learn more, I encourage you to visit www.southcoast.org. I think you'll be impressed. We have been consistent, careful, and thoughtful in our approach to this phase of discussions, which we have now reached. And we will continue our negotiations in that same manner. All the while, we are seeking input from you, the community, and South County Hospital Health System staff. Lou has held a number of open forums for staff, and last month, members of the medical staff at South County Hospital met with some of the counterparts from South Coast. The involvement of our physicians has been substantial in our discussions to date, and that will continue. It is my assessment that our physician colleagues are very positive about this affiliation possibility at this time in our journey. So where we find ourselves now is negotiating a definitive agreement with South Coast, clarifying elements of their proposal. Knowing what we know about South Coast, and that's a lot after more than a year of meetings and talks, we do anticipate that we will reach an agreement with them. But it's important to remember that as of right now, nothing has been decided. Getting to an agreement will likely take many months. And once we have an agreement, we will need to submit it to the state regulators for approval. That process is slow moving. So it would be realistic to expect this whole procedure to take almost a year or longer, depending on how fast things move. In the meantime, our goal is to keep you updated on details and decisions as our talks progress. We welcome your input. I can assure you that we are committed to remaining the same caring, compassionate provider of healthcare services, devoted to the quality, excellence, and safety that you have come to expect. It is your trust in us that drives our dedication, and we will never jeopardize that trust. We have no plans to eliminate services, and as I said earlier, we plan to continue to grow and add appropriate services and providers as necessary to meet the healthcare needs of our community. We are proud of our patient satisfaction scores, our patient safety scores, and our core measures of every interaction that we have with our patients. That will not change. The quality and compassion of our care is our hallmark and remains our pledge to you. Thank you.